Initially, government officials were honest enough to admit that the goal of mitigation efforts, aka lockdown, was to flatten the curve. But the area under the curve, the total deaths from the virus, would likely be the same. In other words, the lockdown was to mitigate the spike in viral deaths so our hospitals would not be overwhelmed, but the same amount of people would likely die with or without the lockdown. The media, and frankly government officials, seem to have forgotten this important caveat. Flattening the curve morphed into a belief that we could change the course of the pandemic with an economic lockdown. This is unfortunate and has led to the protracted lockdown recession we are currently mired in. It's important that we examine the data, learn from the data, and try to avoid the man-made aspect of this calamity in the future. To those who argue that the lockdown flattened the curve in New York and New Jersey, the evidence argues otherwise. New York and New Jersey wound up with the sharpest spike or highest death rate in the world at over 1,700 deaths per million. In contrast, Sweden had a relatively softer touch. Few mandates and mostly voluntary guidelines. Sweden's death rate ended up about a third that of New York and New Jersey. Some might argue that Sweden and New York and New Jersey are different populations, perhaps, but even the average death rate for the U.S. is now greater than Sweden. In fact, the U.S. death rate is quite comparable to less developed parts of the world where social distancing is virtually impossible, such as Brazil, Bolivia, and Ecuador. Which brings us to an important question. Is man really capable of altering the course of an infectious disease through crowd control? The statistics argue a resounding no. The evidence argues that mitigation efforts have failed to flatten the curve, that most countries, regardless of public health policy, suffered a significant spike in deaths and then a gradual decline. Now, some will argue, what about Hong Kong, Taiwan, South Korea, Japan, each which have had extraordinarily low death rates? Hong Kong, Taiwan, and South Korea certainly enforce stricter quarantine and contact tracing rules than the U.S., but Japan's rules were largely voluntary since their prime minister lacks the legal powers to enforce a lockdown. One explanation for the low death rate in much of Asia is that the population may have a higher degree of exposure to coronavirus colds, and therefore have more pre-existing cross-reactive immunity. If scientists were interested, there is a fascinating field of inquiry looking at susceptibility to COVID-19 and assessment of whether people not have pre-existing immunity to similar coronaviruses. In fact, pre-existing cross-reactive immunity to coronavirus may explain why we have so many people that have very little symptoms or asymptomatic. While there's still many things we need to learn about this pandemic, it's important that we, the people, not simply acquiesce to authoritarian mandates on our behavior without first making the nanny state prove their hypothesis. As for now, what we do know is that New York and New Jersey and Connecticut and Rhode Island still allowed the highest death rates in the world. We also know that Sweden, who enforced few mandates, ended up with a death rate 1/3 of New York and New Jersey. We also know that the overall death rate for the U.S. now is essentially equivalent to that of South America, where social distancing and mitigation efforts are virtually impossible. Dr. Fauci, today you said you are not for economic lockdown, yet your mitigation recommendations from dating to baseball to restaurants to movie theaters have led to this economic lockdown. Do you have any second thoughts about your mitigation recommendations, considering the evidence that despite all of the things we've done in the U.S., our death rate is essentially worse than Sweden, equivalent to the less developed world that is unable to do any of the things that you've been promoting? Do you have any second thoughts? Are you willing to look at the data that countries that did very little actually have a lower death rate than the United States?
You know, Senator, I'd be happy at a different time to sit down and go over detail. You've said a lot of different things. You've compared us to Sweden, and there are a lot of differences. And you said, well, you know, there are a lot of differences between Sweden, but compare Sweden's death rate to other comparable Scandinavian countries. It's worse. So I don't think it's appropriate to compare Sweden with us. Yes, we have, I think in the beginning, we've done things based on the knowledge we had at the time. And hopefully, and I am, and my colleagues are humble enough and modest enough to realize that as new data comes you make different recommendations. But I don't regret saying that the only way we could have really stopped the explosion of infection was by essentially, I want to say shutting down, I mean essentially having the physical separation and the kinds of recommendations that we've made.
You've been a big fan of Cuomo and the shutdown in New York. You've lauded New York for their policy. New York had the highest death rate in the world. How could we possibly be jumping up and down and saying, oh, Governor Cuomo did a great job? He had the worst death rate in the world.
No, you misconstrued that, Senator, and you've done that repetitively in the past. They got hit very badly. They've made some mistakes. Right now, if you look at what's going on right now, the things that are going on in New York to get their test positivity 1% or less is because they are looking at the guidelines that we have put together from the task force of the 4 or 5 things of masks, social distancing, outdoors more than indoors, avoiding crowds, and washing hands.
Or they've developed enough community immunity that they're no longer having the pandemic because they have enough immunity in New York City to actually stop.
I challenge that, Senator, because I want to, please, sir, I would like to be able to do this because this happens with Senator Rand all the time. You were not listening to what the director of the CDC said, that in New York it's about 22%. If you believe 22% is herd immunity, I believe you're alone in that.
There's also the pre-existing immunity of those who have cross-reactivity, which is about 1/3 of the public in many estimates from studies, which would actually get you to about 2/3.
I'd like to talk to you about that also because there was a study that recently came out that pre-existing immunity to coronaviruses that are common cold do not cross-react with the COVID-19.
Thank you, Senator Paul. Senator Murphy.
Thank you very much, Mr. Chairman. I'll stay with you, Dr. Fauci. Apologize for not giving you a break. There was a study that got some attention regarding Big Ten and Pac-10 athletes that found that 15% of them who had COVID-19, whether or not they showed symptoms, had evidence of myocarditis, an inflammation and damage to the heart muscle. What are the long-term effects for someone with myocarditis? What is the current understanding of the possible more general long-term effects of somebody who has had COVID and recovered? And are these effects observable in asymptomatic COVID-19 patients?
Yeah, Senator, thank you for that question. I actually had mentioned that in my opening comments, but I thank you for giving me the opportunity to expand on that. That's really quite puzzling because the individuals there were 2 studies. There was one study not in athletes, and then there was the study that you mentioned in athletes. The study in the non-athletes were individuals who had recovered from COVID-19 and had various degrees of involvement, to moderate disease to disease that would require intervention medically. And by doing MRIs, they found that about 60 to 70% of them had indication of inflammatory disease in the heart. Interestingly, they were relatively asymptomatic. So I think we need to be careful and just watch what happens, because one of the possibilities that could develop is that A, it could clear up and they have no problem for the rest of their lives. The other things that they could wind up, when you have inflammation, you could have scarring. That could lead to arrhythmias later on, or that could lead to cardiomyopathies. I have to tell you, I do not know what it would be, but it's something we really need to keep our eye out on.
So insurance companies tend to err on the side of caution. And so what we believe is that because of this uncertainty, because of this potential for long-term health effects, that any diagnosis of COVID, whether you're symptomatic or not, will become a pre-existing condition, and that it is likely, probable, that insurance companies, if they are allowed to discriminate against people with pre-existing conditions, as will happen if the Supreme Court justice is put on the court and the ACA is invalidated, we will see rates skyrocket for anybody who has had COVID. I think something we all need to talk about over the course of the next few weeks. Dr. Redfield, Admiral, I want to come back to this question of the guidance on testing. I think this is really important because, you know, we have to take the president at his word. He announced that he had instructed his advisors to, quote, slow the testing down, please. When folks suggested he was kidding, he was asked by reporters, are you kidding? And he said, I don't kid. Let me just tell you, let me make it clear. So the president made it clear he wants less testing, and so it didn't seem coincidental to us that this strange guidance came out in August that recommended significantly less testing. And yet that's not what you're testifying to today. You're both saying that, in fact, that August guidance didn't recommend less testing, and all you were doing with this third set of guidance in 30 days was to clarify. But where in the August guidance does it tell people that they should get a test if they are asymptomatic but in close contact? Where in that guidance does it actually tell them that they should proactively see a healthcare provider if they have been in contact? Because I've read it 20 times, and I don't see anywhere in this guidance that it tells people they should get a test. I don't see anywhere in this guidance where it tells them that they should go see a doctor. It reads, you do not necessarily need a test unless you are a vulnerable individual or your healthcare provider or your local health officials recommend you take one. That doesn't say you should go to the doctor. That just says if you have been recommended to get a test, you should. So it stands to reason that when folks read this, they will be under the impression that they shouldn't get a test, which seems to comport with the directions of the president. Slow the testing down, please. Where in this guidance that you issued in August does it tell people that they should get a test or they should proactively see a doctor?
Thank you very much, Senator. And as I've said before, I take the position that more tests will actually lead to less cases, particularly if it fully engages public health action. And when I issued the clarification on August 27th, again, I said that we are placing emphasis on symptomatic illness, and also, as you said, individuals with significant exposure, vulnerable populations, critical infrastructure workers, healthcare workers, and those individuals who may be asymptomatic when prioritized by a medical or public health official. The reason that this came from a public health perspective, we were seeing individuals drive up, get a test, and then go on to work. There wasn't a public health action associated with testing. So we calculated that this would help bring a public health action to testing.
But notably, you don't tell people in this guidance that they should go see a doctor.
When we clarified the day after, I put very clearly what the clarification was about the emphasis, and the final category were those individuals who were asymptomatic when prioritized by a medical or public health individual. And again, the intent was for testing to drive an action that was for a public health objective. It was clear through a variety of different reasons when we found that some individuals were not even doing testing for contacts, the individuals with significant exposure, we then put the further clarification. I had thought that the August 27th clarification statement that I put out would carry the football over the goal line. It didn't. But I can tell you there was no intent of this guidance to decrease testing. On the contrary, the intent was to link testing and to drive a public health action. And again, the manner in which it was interpreted by a number of individuals was such that it didn't accomplish that goal.
I think I'm over my time. This has just been dizzying for public health professionals. They're just awaiting the next correction. Thank you, Mr. Chairman.
Thanks, Senator.